Lisfranc injury is the injury of the foot in which one or more metatarsal bones are displaced from the tarsal distal row. So that's where it could be presenting as a subtle injury or a gross, something like a subtle injury like this, or a grossly displaced fractures like this. So up to 0.2% of fractures and 20% of them are missed or diagnosed. And what does a missed injury consequently cause is greater morbidity and disability. So as you know the anatomy, these are the articulations between the cuneiform and the metatarsals, and that's the keystone of the second metatarsal base with the middle cuneiform. So mechanism of injury could be a road traffic accident as we see on the highways, or crush injuries, or even sports related, like what we see a lot in these kabaddi players nowadays. So it could be an indirect trauma where it is a mechanism of force is like directly on a plantar flex and the rotation, or could be direct. It's classified by Quinu and Kus as like isolated, divergent, or homolateral, depending on what type it is. So it could come like any of these patterns. But most important thing is you need to be suspicious of this injury, and you should not label them as midfoot sprains. What are the clinical features that you will get? They'll come with difficulty to bear weight. They'll have swelling across the dorsum of the foot, and deformity depending on the whether it has been spontaneously reduced or not depends on that. Be careful and also look for plantar ecchymosis, which may appear late, and it's important. There could be local tenderness at the tarso-metatarsal joint, and if you gently stress the metatarsals, you will see that there is slight drawers that is positive, and it could be seen over there. So X-rays, it's important that you get standing X-rays so that you can identify each and every component of the fracture injury. So you need a standing epilateral whenever the patient is possible to do that and identify all components of the injury. So on radiology, the second metatarsal ray medial border coincides with the middle cuneiform, and that's the line that you should see. And in a Lisfranc, it could be disturbed. Similarly, the fourth metatarsal is also in line with the cuboid, and that disruption is also seen in a Lisfranc injury. On the lateral, you should see that they are all in line and there is no step off like this. So comparison views are very helpful, and you also need to look out for any associated fractures of the metatarsal shafts, or there could be an avulsion injury of the tibialis posterior from the navicular, or sometimes you could see a lot of fractures happening through the bases of the plantar side of the metatarsals. This is what it comes like. So early recognition is the key to prevent long-term disability, and goal is to obtain and maintain anatomic reduction. So non-operative for non-displaced or very subtle injuries, you could treat them non-weight bearing in a low demand individual in a full contact cast. So it's a short leg cast for 4 to 6 weeks non-weight bearing. You need to repeat x-rays to rule out any displacement as swelling decreases, and the total treatment lasts for almost 2 to 3 months. If you are operating, you need direct incisions between the first, second and third, depending on which area and what tarso-metatarsal joint you are trying to approach. So you could open up like this, see that the Lisfranc joint is open, try and reduce it with screws like this. And while stabilizing, the first thing to be brought back in place is the second tarso-metatarsal joint into the in that keystone area, and that is a rigid screw, rigid fixation, and it's a positional screw and not a lag screw which you're trying to compress it. Nowadays you are followed that by the first metatarsal joint and then the middle column and then lastly the lateral column. Plate or joint spanning low profile plates are also available, and sometimes you can do a combination of plate and screws. Laterally you can, because they are the mobile column, you can fix them with K wires. These are one of our old x-rays. Nowadays there are low profile plates which can be used, and they are seen like this. There are also tight ropes which are there for the Lisfranc's joint, and they are done in this manner. Post-operative care, bulky dressing and splint for 2 weeks, followed by non-weight bearing, foot elevation, look for digital perfusion. Week 2, suture removal, short leg cast for 6 weeks, non-weight bearing. At 8 to 14 weeks, start partial weight bearing. 3 months onwards, protective footwear with arch supports, which continues for almost up to a year. Hardware removal, lateral column wires are removed at 6 to 10 weeks before bearing weight, and medial column implants only after 6 to 9 months. Post-operative sequelae, yes, there is post-traumatic arthrosis, which is seen primarily depends on the force of initial injury and the adequacy of reduction. And if there is arthritis, arthrodesis of the medial column is essential. Also be careful about something called the complex regional pain syndrome, because the foot swelling and makes the foot quite dysesthesia and painful. Also counsel the patient for a long prolonged rehabilitation, as you know the bones join but the foot function takes a long time to come. Thank you.